Bismillahirrahmanirrahim. I am Dr. Mervet Abu Jabal, Professor of Internal Medicine and Rheumatology at Shams University. Welcome to the presentation of this undergraduate lecture in rheumatology. I will share my screen now. My topic today is approach to patient with musculoskeletal rheumatic disease. First of all, what are our intended learning outcomes? By the end of this lecture, a student should be able to determine the principles and concept of musculoskeletal assessment, identify information that need to be obtained in subjective musculoskeletal assessment, formulate hypotheses of the problem, assess and determine the examination procedure that may confirm or refute the hypothesis. Do you know that musculoskeletal rheumatic disease affecting from 20% to 45% of the population? Do you know that more than 15% of all visits to primary care physician are due to rheumatic musculoskeletal disorders? Mostly or usually, the prevalence of musculoskeletal rheumatic disease are higher in women, higher in overweight population, and also are increased in population with lower income and lower educational status. The prevalence of arthritis in women increase with age. Low back pain and other spinal complaints occur in about from 4 to 12% of the population. In general, pain, soreness, aches, stiffness, swelling, weakness, and fatigue account for more than 95% of all initial musculoskeletal presentations. Between 62% to 80% of patients with musculoskeletal complaint for less than 12 months will seek medical attention. However, those with chronic musculoskeletal complaint for more than 10 years will seek medical attention less frequently. Lastly, chronic disability from musculoskeletal disorders affect from 6 to 10% of the population. Now, what are essential components of comprehensive musculoskeletal assessment of patients with rheumatic disorders? First of all, demographic data or personal data. We must gain or ask about demographic data or gain this data from the patient. Then we proceed to subjective assessment, which means detailed history taking. Then objective assessment, which means examination, whether general examination, systemic examination, or musculoskeletal examination of the patient. Starting with demographic data, you must ask about name of the patient, about age of the patient. You must ask about occupation, sports, or activities of daily living. These are very important. You must notice or have an idea about if there is a repetitive movement and the position of limb of the patient at work, as this may predispose the patient to a rheumatic disease like osteoarthritis, for example. Also, you must determine the gender of the patient, as some rheumatic disorders are more prevalent in female, others are more prevalent in male. You must ask about address and residence. In female, especially in childbearing period, you must ask about marital status and age of youngest child. If the female is still married and in childbearing period, and the age of youngest child, for example, from 3 to 5 or 6 years, you must ask why there was no children during the last 3 to 5 years. By asking about contraception. As you know, hormonal contraception, especially that contain estrogen, can result in a flare of most of rheumatic disorder. You must know about it. Also, you must ask about obstetric history of this female. There may be repeated abortion, which can be clue to a diagnosis of important rheumatic disease, which is antiphospholipid antibody syndrome. And this repeated abortion account for absence of childbirth during the last 3 to 5 years. If the female is still menstruating, you must ask about her menstrual history, at least cycle over period. And if there is a menopause, you must ask about duration of menopause and whether this is early menopause that may be induced by the illness itself or by drugs used in treatment of rheumatic disorder. All these data must be gained and are very important in them as demographic data. Lastly, in personal history, you must ask about special habits of medical importance, especially smoking and alcohol intake. After asking about personal history, you must proceed to other components of the history. You must ask about chief complaint of the patient, then components of history, present illness or current history, components of past history of similar condition, past history of medication. If the patient can name these medications and the response to these medications, this is very important. Then you can proceed to family history. This is important also. Also, you must know about ancillary procedures done for these patients previously and review them as you will see. Regarding the chief complaint of the patient, there are certain guidelines. You must write the patient old words, no scientific term. Chief complaint should include the most annoying symptom or group of symptoms that present the patient to you and should include at least the duration of these complaints. Sometimes it may include onset, course, and duration. After complaint, you must ask about components or points or symptomatology in history of present illness. Usually, you start history of present illness by asking the patient about when was the last time he was in good health state. Then start to ask about the first symptom experienced by the patient. Here in history of present illness, you can use scientific term. You must arrange symptoms chronologically. You must analyze each symptom adequately to localize it to a certain system, then ask about other symptoms related to this system in a manner known as symptom system analysis. For example, if the patient in his complaint is complaining of shortness of breath of 1 month duration, as a complaint, this is perfect, no scientific term. But in history present illness, if the condition started, for example, 5 years ago by shortness of breath, you must formulate it like that. The condition started 5 years ago by dyspnea. This is scientific term and can be used in history of present illness. Now you must analyze this symptom, dyspnea. You must ask the patient if this dyspnea was exertional or at rest. And if exertional dyspnea, you must grade it. Dyspnea with more than ordinary exertion is grade 1. Dyspnea with ordinary exertion is grade 2, while dyspnea with less than ordinary exertion is grade 3. Dyspnea at rest is grade 4, which indicates serious situation. But this is not enough. After grading of the dyspnea, you must localize it to certain system. Dyspnea could be produced by cardiovascular disease, could be produced by respiratory disorder, or may be related to anemia as general manifestation of anemia. So after grading of dyspnea, ask the patient if it is associated with orthopnea or paroxysmal nocturnal dyspnea. If so, this dyspnea will be related to cardiovascular disorder. You must ask about other symptoms related to cardiovascular disease. For example, you must proceed to ask about palpitation and analyze it. You must ask about cardiac chest pain and analyze it. You must ask about symptoms suggesting systemic venous congestion or cardiac edema in general, and so on. If this dyspnea was not associated with orthopnea or paroxysmal nocturnal dyspnea and may be related to respiratory system, ask about if this exertional dyspnea is progressive and associated with dry cough, for example. This may indicate interstitial pulmonary fibrosis, which is related to pulmonary affection or pulmonary disease. Like interstitial pulmonary fibrosis. So you must proceed to ask about other symptoms related to respiratory system. For example, you ask about occurrence of cyanosis. You ask about occurrence of manifestation related to mediastinal syndrome. You ask about cough and expectoration. You ask about hemoptysis and so on. As I said, in a manner known as symptom system analysis. adequate analysis of any symptom, localize it to certain system, then determine the extent of affection of this system by asking about other symptoms related to this system. If this dyspnea is not related to cardiac disorder, not related to respiratory disorder, it may be related to anemia as a general manifestation. In this condition, the patient will suffer from exertional dyspnea, exertional palpitation, and blackout. With each symptom, you must determine onset, course, and duration. Also, you must determine the response to therapy if treated. Now, in musculoskeletal sheet or in history of rheumatic disorder, there are certain points must be fulfilled. These points or symptoms starting by pain, and here by pain I mean pain in joints. As we are in history present illness, we can use scientific term and name it as arthralgia. Pain in joint mean arthralgia. Like any pain in medicine, you must ask about onset, course, duration, side characterization, what increase, what decrease, and associated symptoms. But here in rheumatology, it's very important to interpret this pain or conclude if this pain is usage pain, pain with use of joint, relieved by rest, it will be related to mechanical or degenerative disease. Or if this pain is rest pain occurring even during rest of the joint, which indicate presence of inflammatory joint disease. And by inflammatory joint disease, I mean synovitis. The second symptom you must ask about in musculoskeletal sheath is stiffness. Stiffness means difficulty in initiating movement of any joint, which lasts for some time, then improve gradually and start to improve gradually, especially in early morning. There are two types of stiffness. You must determine which type is present in this patient. Joint stiffness may be inactivity stiffness after short period of inactivity, which lasts for less than half an hour, known as gelling, then followed by improvement. This is characteristic to non-inflammatory or degenerative joint disease like in osteoarthritis. The other type of stiffness is known as inflammatory stiffness, which occur after prolonged period of inactivity, for example, after night, after sleep at night. So it's usually this is morning stiffness, which lasts more than half an hour and indicate presence of inflammatory problem and is due to accumulation of inflammatory excrete inside the joint, which result in joint stiffness, increased intra-articular pressure, and limitation of movement. It lasts for more than half an hour, then start to be absorbed, this inflammatory excrete, and stiffness improve. After asking about the stiffness, you must ask if there is a swelling, if this swelling is related to joint, or if there is extra-articular swelling. Like any swelling, you must ask about its onset, course, duration, its site, whether related to the joint or extra-articular. If this swelling is painful, if this swelling is itchy, what about the overlying skin? If there is abnormal discoloration or pigmentation in the overlying skin, especially if associated with hotness and redness and is related to joint, this means arthritis and not arthralgia. Also ask if there is oozing, something oozing from the swelling. After asking about the swelling, you must ask if there is deformity, especially in presence of long-standing joint disease. Grossly, the patient must describe his deformity, whether there is flexion deformity, extension deformity, but later on in examination, you must precisely describe this deformity. After long-standing arthropathy and occurrence of deformity, you must ask about occurrence of disability with or without handicapping. Disability describe joint condition. Disability of the joint indicate loss of function of this joint. For example, knee joint, if there is lost flexion and extension, this indicates there is disabled knee joint. And if there is disability, and if this disability affecting patient's social and occupational life, the patient will be handicapped. So disability describes joint state, but handicapping describes the patient himself. Sometimes disability is not enough to produce complete handicapping of the patient, and there is just decreased functional capacity or functional performance of the patient. You must report this. All these symptoms, pain, stiffness, swelling, deformity, disability, and handicapping, are related to joint affection. Now, you must ask about if there is extra-articular manifestations, either by asking the patient what are other symptoms experienced by him and start to analyze them one by one, or by giving guiding questions to the patient about symptoms related to all systems all over the body, starting by skin, hair, nail, mucous membrane affection, cardiovascular symptoms, GIT manifestations, hematologic manifestation, renal manifestation, muscle affection, especially proximal muscle weakness or affection. Also, you must analyze all these symptoms related to these symptoms, these systems adequately. In the same way I mentioned before, symptom system analysis. Don't forget ocular manifestation, neuropsychiatric manifestation, and any medication taken by the patient during his current illness, and what was the response to these medications. Lastly, you must ask about constitutional manifestation of disease like fever, and analyze this fever adequately, headache, fatigue, anorexia, or weight loss. Then you must proceed to the past history. Ask about previous episode of same condition that will provide the therapist guideline for prognosis, treatment, or diagnosis. The patient may have different condition in the past that may predispose him or her to the current condition. For example, the patient may have recurrent tonsillitis, for example, in the past, which results now to occurrence of bleeding arthritis of rheumatic fever. Also, in the past, you must ask about common conditions like diabetes mellitus, hypertension, tuberculosis or admission into chest hospital, hepatitis C virus infection, or performance of major operations, intake of blood transfusion, which may be indirect indicator to occurrence of hepatitis C virus infection. Ask about the previous diagnosis of osteoporosis, which may account for the current pain now due to presence of fragility fracture, for example. Ask about important system disease like renal disease, previous hepatic disease, or peptic ulcer disease. This is very important as these provide precautions or contraindications to various treatment strategies. Now proceed to ask regarding family history. Note diseases or disease process that have familial incidents. For example, tumor, heart disease, arthritis, allergies, diabetes. Family history predisposes the patient to increase risk for acquiring the same condition. Regarding social history, is not part of classic history in our country, but at least you must ask about the lifestyle of this patient. If it's sedentary lifestyle, or the patient is performing regular exercise, for example, ask about his living condition, as you will find that lifestyle modification is very important non-pharmacological component of patient management later on. Ask about drugs taken by this patient, either during his current illness or in the past. This will identify medications taken by the patient, their indication, their dose, especially analgesic, steroid intake, and maintenance medication. Side effects of medication should be considered, as this may interfere with the treatment. You must ask about any ancillary procedures done for the patient, either during his current illness or in the past, as this may either rule out or confirm the presence of a condition that result to the patient symptoms. You must revise all laboratory and diagnostic tests performed, review available records, review other clinical findings. This ancillary procedure may include previous chest X-ray, previous MRI, previous CBC done for the patient, previous nerve conduction study, or even previous reports, medical report wrote by a physician to this patient. Now, after taking perfect detailed history with all its components, you can answer these questions, which help you to put provisional diagnosis. Is the problem in this patient is articular? Is there joint affection or non-articular, and mainly there is extra-articular manifestations? Is this articular disease is acute, listed less than 6 weeks, or it's chronic, listed more than 6 weeks? Is this problem is inflammatory or non-inflammatory? By inflammatory, we can conclude if there is inflammatory joint disease. This means synovitis, as I said, by presence of rest pain, by presence of swelling, hotness, with or without erythema overlying the affected joint, by presence of inflammatory burning stiffness lasting more than 30 minutes. This mentioned or point to presence of inflammatory joint disease. If there is joint affection, you must determine the pattern of this joint involvement. By the pattern, I mean, is this condition affecting single joint? It will be monoarticular disease, or oligoarticular disease affecting 2 to 4 joint area, or polyarticular disease affecting more than 4 joint area. If this joint affected or joints affected are bilateral and symmetrical, or bilateral but asymmetric, or if they are unilateral. If this joint affection is axial or peripheral, or both axial and peripheral. If this joint affection occurring in intermittent manner, or fleeting manner, or additive. By fleeting arthritis, we mean when the new joint is affected, the previous one is still, when the new joint is affected, the previous one is completely normal. This is fleeting arthritis. But additive arthritis, when new joint is affected, the previous one is still suffering residual manifestation. There is still swelling, still pain, still limitation of range of movement, still hotness, still there are symptoms. This is additive arthritis. Also, you must determine if this arthritis affecting small joints or large joints, or both. If this arthritis affecting joints of upper limb, or mainly lower limb, or both. This regards the pattern of joint involvement. After fulfilling or answering this question, answer the last question, which is helpful also in putting differential diagnosis. Are there extra-articular manifestation in this patient in addition to the articular manifestation? And if so, what are systems affected in this patient? Now, after completing history and answering examination and answering questions, proceed to objective assessment, which means essential general examination and essential systemic examination according to or guided by data obtained from history of the patient. This objective assessment is important for documentation of the patient baseline level of function and the status. Also, you perform tests and measures which vary depending on area to be examined and information obtained from subjective assessment of the patient. During objective assessment or musculoskeletal examination specifically, you start by inspection, then palpation, then test for range of motion, starting by active movement done by the patient himself. If there is defect in active movement, proceed to perform passive movement by yourself or by the doctor. Don't forget to evaluate gait and posture of the patient. Don't forget to perform a special test according to the area examined. Sometimes examination for special examination or neurological examination for muscle and nerve may be required in certain situations, as you will see. Starting by inspection, on examination of or inspection of any joint area, start by skin overlying the affected joint or skin overlying the joint in general. You must comment or inspect for presence of skin abnormality like abnormal pigmentation, hyper or hypopigmentation, abnormal skin rash, and describe this rash, abnormal discoloration, especially if there is triad of color change in distal extremities, which indicate presence of Raynaud phenomena or exposure to cold weather or coldness, abnormal or fixed discoloration of distal extremities, for example, become bluish or blackish, together with occurrence of ischemic manifestation like fingertip and toe tip beating scar and ulcer, which indicate ischemia. Comment on this. Also, other skin manifestation, you must comment if there is a scar of operation or arthroscopy. Comment if there is abnormal skin shape. The skin if appear thin and shiny, which is characteristic in case of scleroderma. You must comment on this by inspection. Following skin examination or inspection of the skin, proceed to inspection of nail changes. Nail abnormalities include loss of luster, onycholysis, which mean separation of nail plate from nail bed, either partially or complete separation of nail plate from nail bed, or subangual hyperkeratosis, separation of nail plate from nail bed by a layer. These abnormalities, loss of luster, onycholysis, subangual hyperkeratosis, collectively are known as nail dystrophy. These dystrophic nail changes are one of criteria that help diagnosis of psoriatic arthritis or psoriasis of nail in general. This help diagnosis of ischemic manifestation of scleroderma and could be present in cases of hypocalcemia and in cases of peripheral neuropathy. Then, after examination of nail, inspect for presence of muscle atrophy or muscle wasting, especially in muscles related to the affected joint. This could be determined by either observe for hollowing of contour. Certain muscle have special contour like deltoid, like quadriceps muscle, like gluteal muscle. If there is hollowing of contour or loss of normal contour, this will indicate presence of muscle atrophy. Or in presence of unilateral muscle wasting, you can use measurement. You can measure the limb circumference on both sides to determine occurrence of unilateral wasting. Then proceed to inspect for any swelling, whether this swelling is related to the joint or extra-articular or peri-articular. And you must describe by inspection the site of this swelling, the shape of this swelling, its size, its relation to surrounding structures, is the overlying skin, whether normal or abnormal, whether this is swelling oozing something or not. Then proceed to inspect for any deformities. Now you must describe these deformities precisely. For example, describe Z deformity, describe Swan-neck deformity, describe geniovarus deformity, if there is flexion deformity in the elbow, and so on. And if there is any color changes all over the body. After completing inspection, proceed to palpation of the affected joint or the examined joint. Usually, we prefer to start by evaluation of temperature of the affected joint using the dorsum of your hand, comparing the temperature of the joint with temperature of the skin proximal to this joint area. If there is increased temperature of the affected joint, this indicates hotness, indicate presence of inflammation. Following temperature, examine, palpate the joint for tenderness, especially along joint line. Tenderness along joint line indicate presence of synovitis. Also, palpate for joint margin tenderness. This tenderness is usually due to presence of bony spur or osteophytes in cases of osteoarthritis. Now proceed to examine the deformity. whether correctable or non-correctable. This is by trying passively to correct this deformity, especially in cases of rheumatoid arthritis. If it is correctable deformity, this indicates that the problem is in periarticular structures, in ligaments and tendons surrounding the joint, and this is early, for example, in rheumatoid arthritis, and you can introduce aggressive therapy or more intensive therapeutic modalities to prevent occurrence of joint ankylosis and non-correctable deformity. But late in this course, this deformity will be non-correctable. It will not be corrected passively. This indicates occurrence of ankylosis of the joint, whether fibrous or polyankylosis, and will not be corrected except by surgery. Then you can palpate for tissue texture, especially in presence of thin shiny skin by inspection, which may point to the presence of scleroderma. Try to pinch fold of skin and feel this skin texture to determine if there is hard, tight skin. In cases of scleroderma, this is bedside test to confirm presence of sclerosed skin. In certain situations, for example, suspicion of carpal tunnel syndrome or in general entrapment neuropathy, especially in cases of rheumatoid arthritis and scleroderma, in suspicion of presence of bone neuritis multiplex or peripheral polyneuropathy, for example, in cases of vasculitis, whether primary or secondary, you can proceed to palpation for abnormal sensation. If there is hypoesthesia, if there is hyperesthesia, if there is anesthesia. Lastly, you must examine the joint, especially large joints exposed to occurrence of osteoarthritis, palpate them for crepitus. But notice, you must palpate the joint while the joint is moving, either actively by the patient or passively by you to feel coarse crepitus of osteoarthritis. Now, after inspection and palpation, proceed to test for range of movement. Start by active movement. This is very important. Try to notice when and where your movement, the onset of pain occur. Try to notice the quality of movement. If the patient is performing the active movement rapidly, smoothly, without tricky movement, without severe pain or not. If there is defect in performance of active movement at any joint, proceed to perform the movement passively by yourself. This helps differentiation between articular and periarticular problems. In articular problems, there is a limitation of both active and passive movement to the same extent, and usually in all plane of movement of the affected joint. While in periarticular problems, there is a more affection of active movement. The passive movement is much more better, and usually affection of active movement is in one plane of movement only. These are different range of movement, active movement. We will perform it with the patient in clinical round. Lastly, don't forget to evaluate the gait of the patient. There are certain guidelines for evaluation of patient gait. These are the patient should be assessed both in normal footwear and in barefoot. Take time to observe the patient during gait assessment. Assess in anterior, posterior, and lateral view. Not use of gait aid. This is important. During your evaluation of the gait, you must determine if there is abnormal gait pattern, if there is difference between right and left lower extremities in gait, if there is compensatory mechanism or tricky movement by the patient, and what about the speed of walking. In fact, gait is composed of two phases, stance and swing. The patient performs 4 steps during these phases. The first step is heel strike, then stance, then toe off, then swing. Don't forget, normal gait components are heel strike, stance, toe off, and swing, for constituting the 2 phases of normal gait. If there is deviation from these steps, you can report that there is abnormal gait. This abnormal gait may be due to musculoskeletal disorder, maybe due to orthopedic disease, maybe due to neurological disorder. Now, after taking detailed history, after performing comprehensive examination, mainly musculoskeletal examination, inspection, palpation, movement, starting by active movement, followed by passive movement if necessary. Then, after performing the essential general examination according to the condition of the patient and the essential systemic examination according to the condition of the patient, you can answer these questions again, but more efficiently. Is the problem is articular or non-articular? Is it acute or chronic? Is it inflammatory or non-inflammatory? Is this joint affection? What is the pattern of joint involvement? If there is extra articular manifestations, and try to localize them to systems which are affected in this disease. Now, this table helps you to differentiate between inflammatory and non-inflammatory joint condition. In inflammatory joint conditions, joint pain is mainly rest pain, while in non-inflammatory, usually it is usage pain. In inflammatory joint condition, swelling, erythema, and hotness are present or are common finding, but in non-inflammatory, usually they are absent. And if there is tenderness or if there is tenderness in the affected joint, it will be joint line tenderness in inflammatory condition. But in non-inflammatory, it will be marginal tenderness due to bony spur. Regarding morning stiffness, in inflammatory condition, it lasts more than half an hour, but in non-inflammatory condition, it lasts less than half an hour. Regarding systemic manifestation are common in inflammatory joint disease, but very rare or absent in non-inflammatory joint disease. There are a group of investigation which help confirmation of presence of inflammatory joint disease, like high ESR and C-reactive protein as acute phase reactant, low hemoglobin in inflammatory condition, but there is normal ESR and C-reactive protein in non-inflammatory condition and normal hemoglobin. Also, low serum albumin in inflammatory condition as it is negative acute phase reactant, but usually normal in non-inflammatory condition. If there is availability of synovial fluid aspiration, the synovial fluid in inflammatory condition will appear turbid. White cell count, total white cell count is more than 2,000, and the polymorph nuclear leukocyte constitute more than 75% of total leukocyte count in inflammatory condition. But in non-inflammatory condition, usually the synovial fluid is clear, straw yellow, total leukocyte count less than 2,000, and the polymorph nuclear leukocytes constitute less than 75% of total leukocyte count. Now you can put provisional diagnosis. Before this, you must ask yourself, is the condition is pure joint disease, pure arthropathy, like in traumatic joint disease, like in degenerative joint disease, like osteoarthritis? Or the condition is multi-system disease? If there is multi-system affection in addition to joint affection as one system of these systems, it will be connective tissue disease, as connective tissue disease is characterized by presence of multi-system disorders. According to the predominant system affected, you can determine which connective tissue disease is a diagnosis, is a proper diagnosis. Connective tissue disease like systemic lupus erythematosus, like scleroderma, like dermatomyositis and polymyositis, like mixed connective tissue disease, even rheumatoid arthritis is connective tissue disease characterized by multi-system disorder. And if the most likely diagnosis is multi-system disease, this means connective tissue disease, this is not enough diagnosis. You must determine if this connective tissue disease is present alone or as part of mixed connective tissue disease or as part of overlap syndrome. For example, if the most likely diagnosis is multi-system disease fit to systemic lupus erythematosus. Is systemic lupus erythematosus present alone or part of mixed connective tissue disease? In this condition, it will be associated with manifestations, in addition to systemic manifestation of systemic lupus, it will be associated with manifestation of scleroderma and manifestations of polymyositis. Or this systemic lupus erythematosus is part of overlap syndrome. The commonest overlap with systemic lupus erythematosus is with rheumatoid arthritis, for example. After putting provisional diagnosis of certain connective tissue disease, make sure if this connective tissue disease is present alone or present as part of mixed connective tissue disease or overlap syndrome. If not arthropathy, the condition is not related to joint and is not multi-system disease fit to any of the connective tissue disease, it may be soft tissue rheumatism, like in plantar fasciitis, which may be present as isolated rheumatic disorder in the patient. Plantar fasciitis may be idiopathic autoimmune or due to mechanical cause, or maybe, for example, panniculitis, inflammation of subcutaneous fat, immune inflammation of subcutaneous fat, which may be present as isolated disorder. You must determine this to put proper differential diagnosis. Once you put the most likely diagnosis with or without differential diagnosis, you must ask for investigations. These investigations are for confirmation of the most likely diagnosis and for exclusion of other differential diagnosis, and then to assess the disease itself, the most likely diagnosis, its extent, its activity, its severity, and to determine important system function like renal function, hepatic function to be considered when you write medications or therapy to this patient. Once you confirmed your diagnosis, excluded other differential diagnosis, determine the extent, activity, and severity of the most likely diagnosis, determine if there is other system, important system affection, you must put your therapeutic plan, starting by patient education, then non-pharmacological therapy, then pharmacological therapy suitable for this patient, and you must also determine how will you monitor this patient and follow up him. Thank you for your time, hoping this could help you to properly and comprehensively assess your patient with rheumatic disorder. Prepare your question to discuss and to answer in face-to-face session. Thank you.